was other than that, it was fairly peaceable.
And they had the OK corral.
That's
Right.
right.
Now, ladies, gentlemen, I am going to start. And the first thing I want to do is welcome Dr. Fairleigh Reeves, who is our guest speaker for this evening. So thank you. Before I introduce her fully, the usual housekeeping. The usual housekeeping is fairly precise. The meeting is being recorded and will be available to club members, subject to passwords, etc. And we will be collecting questions for the Q&A, and these will be moderated tonight by Brian Timms. Thank you again, Brian, as always, for doing this. Jeremy not being around tonight, but Brian is the main one, so thank you.
And I'll try to handle the medical ones.
I think you'll handle them pretty well, no. Right, so that's that. And the usual stricture on the chat function. The chat function is there for questions and not for commentary on the speaker or on the convener and chair. Thank you. So just keep that down to the questions, please, and for Brian. So Fairleigh is going to give us a presentation using slides, as often happens, and then we'll have about 30 minutes for question and answer. So our speaker, Dr. Fairleigh Reeves. Now, some of us were brought up on Catch-22 and we learned about major. Fairleigh, of course, is Doctor, because she's a medical doctor with a PhD also in the similar area. Melbourne University being quite important. I'm not going to go through her CV, except to say we're quite honoured to have such a specialist, someone on the cutting edge, to put it bluntly, as Fairleigh tonight. And Fairleigh is one of the speakers, as has happened in the past with several other speakers, importantly, who's been strongly recommended by one of our members. So thanks to Dick Davies. Over to you, Fairleigh. I'm not going to dwell on your CV, but to say welcome, thank you very much.
Introduction. Can you hear me okay?
I can hear you, and I'm going to mute.
Fantastic. I'll just share my slides. All right. Thank you again for the introduction. As you know, I'm going to be focusing on prostate cancer tonight. Are the slides showing up okay? A nod.
Yeah, yes.
Slides are quite clear. Yes.
Yep, they're fine.
Apologies in advance. It's a bit of a whirlwind tour because it's a big topic and I wanted to make sure we've got time for questions. So I'll try and get through as much as we can. I do have an interest in robotic kidney and prostate surgery, but also look after general urology conditions. From a public perspective, I work at the Royal Melbourne Hospital and also the Prostate Centre in North Melbourne, and privately at Epworth and Knox Hospital. So today, what is the prostate? We'll talk a little bit about any symptoms that you may find you have as a result of prostatic issues, but the main crux will be prostate cancer, looking at some statistics, some tests that we would use, and also just general treatment principles for either localized or metastatic disease. So the prostate is an organ that sits just underneath the bladder. It sits deep within the pelvis, just in front of the rectum. Now, it varies hugely in size, so it does grow as you get older, and so it may vary something between about 20 grams to more than 200 grams. In terms of any symptoms you may have from the prostate, now it's helpful to understand that there are different zones of the prostate. The central and transition zone that lives just around the urethra tends to be what is affected by benign enlargement of the prostate, which, as the prostate grows, it compresses the urethra and gives you those symptoms where you've got poor flow, trouble starting the stream, dribbling at the end, you're perhaps getting up at night to go to the toilet. There can be urinary frequency and urgency. Now, these symptoms, although not always, are often benign because that's where that benign growth is. You can get blood in the urine from the prostate, but Not always. And so if someone has blood in the urine, as urologists, we want to check the whole urinary tract, but in particular, we want to make sure we exclude bladder cancer. The trouble with prostate cancer is it tends to be in the periphery of the prostate. So it doesn't often compress the urethra, and so doesn't usually present with local symptoms, although it can. More commonly, it presents quite late after the disease has spread, and that would usually be to the bone where you get bony pain. So I guess before I move on, if we have time at the end, I've got a couple of slides just on benign prostatic symptoms and how we treat those, but I wanted to keep the focus on prostate cancer for tonight. So how common is prostate cancer? Well, if I went down the street and took a biopsy of anyone over the age of 80, most men would have some degree of prostate cancer, but not everyone's actually going to be affected by it. So this data on the left here is just from autopsy series showing how common prostate cancer is if we were to look for it in everyone. Well, what do the statistics look like locally? Prostate cancer is incredibly common. 1 in 10 men will be diagnosed before they're 75. It's the second most common cancer in Australia, and also the second most common cause of cancer-related death in men in Australia, behind lung cancer. Having said that, it generally has a very good survival rate. If you can see on the right, the graph shows the prostate cancer statistics from Victoria, and most commonly men tend to be diagnosed in their late 60s or early 70s. And in Victoria, prostate cancer accounts for 7% of all cancer-related deaths. So who is at higher risk? Ethnicity definitely plays a part. So both your ethnic background, but also where you live. So African descent, so Afro-Caribbean, African-American, they would be the highest risk group. Indigenous Australians also have poorer outcomes. Probably the lowest risk group are Asian men, in particular Japanese. But we do know that there is some environmental factors, because if you take, say, a Japanese man and move him to America, he does assume some of the increased risk in the United States, but not all. Family history is very important. So if you've got one first-degree relative, you're 2 times the risk of prostate cancer. And as the number of relatives you have go up, as does your risk. Having said that, the minority of cases are truly hereditary. So hereditary has quite a sort of discrete definition, and in those cases, patients tend to have an earlier onset of disease, but actually the aggressiveness and the outcome is unaltered. As I'm sure many of you have heard of, the BRCA mutation, which is involved in breast and ovarian cancer, is also implicated in prostate. So when we're taking a history from people, we want to know about not only the history of prostate cancer in their family, but also other malignancies, because there may be other syndromes that run in the family that are relevant to prostate cancer. With respect to the environmental risk factors, as I said, no doubt there is environmental factors at play. Unfortunately, there's no conclusive evidence to point towards specific dietary or pharmacological, so medication interventions that we can use to prevent prostate cancer at the moment. The best advice we really have is probably for a Mediterranean diet in terms of outcomes with prostate cancer, which really just means a very healthy, balanced diet. So genetic testing, I know there were some questions coming through about this before the meeting. I won't go into it in a lot of detail, except to say it's really important to understand the difference between germline testing and somatic testing. So germline testing is when you take blood test or saliva and you're looking at what mutations may have you inherited that's going to affect your inherent cancer risk. One of the challenges with these sort of tests is, understandably, people are nervous about what the implications might be for either their insurance or even their children's insurance if there was some sort of abnormality detected that's going to put them at increased risk of disease in the future. One of the other challenges is it's not a case of just testing 1 or 2 things and saying, yes, you know, you're at risk or not. There are more than 100 identified abnormalities that contribute to prostate cancer risk. And I've just listed a handful of the most common ones there, including BRCA, which I spoke about briefly before. The other type of genetic testing is somatic testing, where you actually take the tumour and just test this for any genetic changes, and this can help inform treatment options. And so genetic testing is not something we often offer to men with a new diagnosis of low-risk cancer, but if you've got advanced or metastatic disease, then that will definitely be something that would be taken into consideration. Or if you've got a very young age at diagnosis and we wonder, oh gosh, is there something running in the family, then we would recommend seeing a genetic counsellor. So PSA testing really is where the diagnostic algorithm begins. As many of you may know, the PSA is a blood test. It stands for prostate-specific antigen. It's a protein that's produced by the prostate and can be detected in the blood. And the purpose of testing the PSA is that early prostate cancer rarely causes symptoms, as I mentioned before. And if we can detect it early, we can offer a survival advantage. In 2008, 2012, in the United States, there was a recommendation to abandon PSA screening, and we saw quite clearly there was a real drop-off in the diagnosis of localized disease. It makes sense if you're not testing for it. But in time, they saw a real uptick in the diagnosis of locally advanced and distant disease. They've now changed their mind and have gone back to PSA testing, but it quite clearly showed with the change of practice that the change of diagnosis was evident. So what's an abnormal PSA? We tended to use these tables from previous population-based studies to say, okay, as you get older, your PSA tends to go up. And that was really all we had to rely on. Somewhat related to the Medicare funding for MRI, and I guess just to keep things a little simpler for GPs and everyone, we've simplified rough cutoffs at which you should do further testing. So under 70, we recommend further tests if your PSA is above 3 and over 70 above 5.5. These are just general guidelines though, they're not absolute figures. So who should have a PSA test? The current guidelines locally recommend testing every 2 years from the age of 50 to 69. But if you've got a higher risk because of your family history, then depending upon the degree of your risk, we would say start testing at age 40 to 45. The most important thing though is that men having PSA tests should have a life expectancy of more than 10 years. And that's because if we're looking at curative treatment, we're actually looking at preventing a problem 10 to 15 years down the track. So the PSA testing really is looking at long-term outcomes. Why is it controversial? I'm sure many of you have had conversations with your GPs, and the GPs really find it difficult because their guidelines keep changing. No doubt it is an imperfect test. So prostate cancer unfortunately can exist if there's a normal or a low PSA. So that's why I'm particularly interested in the trend. So is there a change, not just the absolute number? And it also can be raised in the absence of cancer. So if there's inflammation or infection, and so that may lead to unnecessary tests, including biopsies, which of course in turn has stress related to that. One of the biggest criticisms of PSA testing previously was the over-treatment of men with low-grade disease who may never have had problems with the cancer in their lifetime. I think we've seen a huge shift in the way prostate cancer is managed, so that a lot of men are now on a surveillance program, which I'll talk about more. And so we're really doing our very best to make sure that even if we're diagnosing low-grade cancer, people are well informed, and that doesn't necessarily mean they have to go on to have treatment. I've got one slide in here because I know that this saliva test made it into the mainstream media. The Barcode 1 study was presented at an oncology conference earlier this year. It was a study from UK that looked at European men and took saliva samples to check for those germline mutations I spoke about. Now, as I alluded to before, because it's just not one or two different genetic abnormalities, what they did was created a polygenic risk score. So anyone who was above the 90th centile on this, they were actually invited for an MRI and a biopsy. What was interesting about the study is that 64% of the patients were at a PSA level that wouldn't meet our current threshold for doing tests. And they did detect a significant number of cancers that we would call clinically significant, so not just low risk ones. And they also did find that MRI did miss some cancers. So all patients who were above that 90th centile had both the MRI and the biopsy. This is still in a research space, though, and not something we have access to currently. But I certainly think that these polygenic risk scores and similar things will make it into mainstream care in the not too distant future. So coming back to our current practice, your PSA is high, what happens next? First thing is you need to repeat it, because the PSA can fluctuate. It may have gone up for one of those other benign reasons. And so we don't want to leap into further investigation straight ahead. The next step would be, especially if you see a specialist, is a digital rectal examination. So sometimes we do find an abnormality on examination that's suspicious, even in the absence of an elevated PSA, or perhaps you don't quite meet that threshold that Medicare recommends regarding an MRI. So we would still do an examination, and then the next step is an MRI of the prostate. So the MRI has really changed the way we manage and investigate prostate cancer. It detects about 90% of clinically significant disease. So these pictures, MRI is definitely a long learning curve. So it's really important that the scans get done at not only a place that has a good quality scanner, but also a dedicated MRI prostate reporting radiologist, because notoriously we do get scans that are incorrectly reported from places that don't have a special area of interest with this. You can see we get a series of different images. The arrow points to how looks slightly different on each of those different pictures, but they all match up. Now, if any of you've had an MRI scan, you may have read the report. It's an internationally standardized grading system. So they use this system called PIRADS. 1 and 2 basically means the radiologist isn't very suspicious that there's anything there. 3, it's equivocal. 4 and 5, they're more worried that there's a cancer. And in the studies where someone's then gone on to have a biopsy, you can see that the likelihood of cancer targeting those areas with a biopsy goes up as the PIRADS score goes up. The other thing I find incredibly helpful from the prostate MRI is understanding the prostate size. So the MRI will give us a volume of the prostate, which allows me to calculate a PSA density. So if you remember back to those tables where the PSA starts to go up as you get older, that's probably because the prostate grows as you get older. So by calculating a PSA density, it allows me to work out, well, what's a PSA that I'm comfortable with for any individual person. So we don't have to have this sort of one size fits all threshold for everyone. If either the PSA density is very high or there's a lesion on MRI, the next step is a biopsy. Traditionally, that used to be done via the transrectal route. So passing a needle through the rectum into the prostate, that was understandably fraught with infection risk because of the fact it was going through the fecal passage. We now use transperineal biopsy, where the needle goes just through the skin just under the scrotum. That's ultrasound guided. It can be done under local or general anaesthetic, and it's a day procedure. We take samples of the area of the MRI concern as well as systematic samples of the prostate. You get your biopsy result back. Now, basically, the pathologist has a look under the microscope and gives us a score to give us a sense of how aggressive the cancer is or not. The traditional scoring system is the Gleason score. That's calculated by giving the 2 most common cell patterns, as you can see in that picture there. but it's a bit of a confusing system because it goes from 6 to 10, which is not an easy thing to get your head around. So the more recently it's been converted into the ISUP grade group, which is 1 to 5, but it's effectively the same thing. So we'll often use the terms interchangeably. 1 is the least aggressive and low risk, and 5 is the highest risk. So with information of your PSA and the Gleason or ISUP, we start to group people into low, intermediate, and high risk. And low risk is a group of people who are more likely to die with the cancer, not from it. And intermediate, the cancer is more aggressive and there's a higher potential to do harm. And then, of course, with high risk, you're much more likely to be at risk of having metastatic spread. If you've got intermediate or high risk, then we need to do scans to check if the cancer's outside of the prostate at all. Traditionally, that was done with a CT and a bone scan, and that's a bone scan on the left that you can see there. We now use information from the MRI to look for any local lymph nodes and also a PSMA PET. This is basically a prostate-specific PET scan, so a cancer scan, looking at the whole body to see if there's any distant disease. And this is Medicare funded for anyone with intermediate risk disease. It gives us much, much more accurate information than we've had before. Looking at the patterns of disease diagnosis locally, so from Victoria in 2021, around 6% had disease outside the prostate at the time of diagnosis, but the most people who are diagnosed with low-grade or intermediate grade disease. When we're looking at assessing someone and considering treatment, of course we take into account the disease factors, which we've talked about, but I also want to know about their family history, because if someone comes to me and they've had 3 brothers with aggressive prostate cancer treated at the age of 50, I'm much more likely to be quite cautious with that person. Other patient-related factors such as their age, their other medical conditions and their life expectancy, of course, are all very important too. So everything really comes back to that low, intermediate or high risk in terms of deciding what sort of treatment someone should have. Historically, anyone with very low risk disease would be offered active surveillance, and I'll explain that in more detail shortly. And then anyone with a reasonable amount of low risk disease or anything higher risk would be recommended radical treatment with a prostatectomy or radiotherapy. We've seen a real shift in the way that prostate cancer is treated, such that virtually everyone with just low risk disease would be recommended for surveillance. And we're starting to see more men with intermediate risk disease, not everyone, but more men who we also think are suitable to monitor because they're unlikely to run into harm during their lifetime. That's definitely an area of further research, because we're still needing more information on how to best risk stratify these people and decide who is safe to watch and who isn't safe to watch in that group. So, active surveillance, there are 2 different types of monitoring for who've got prostate cancer. Active surveillance is for someone who we are intending to cure. We're saying you've got low risk disease and we're going to monitor you very carefully. And if on any of your tests there's an upgrade in the risk of disease, we are going to offer you radical treatment at that point with the intention still to cure. And the whole purpose of active surveillance is deferring treatment so that we can avoid people being subject to side effects for treatment that may or may not help them. So we wait until we reach a trigger point to intervene. Watchful waiting, on the other hand, is where we're really just focused on symptomatic management. So this is for people who've got a short life expectancy, or maybe you've just got a lot of medical issues that are much more likely to cause you trouble than the prostate cancer. And so for these people, we still may monitor, but our intervention is really only going to be focused on quality of life. And so our intensity of monitoring is going to be tailored to the individual rather than on active surveillance where it's really quite regimented. So if we're then talking about radical treatment for prostate cancer, the 2 mainstays of treatment would be radical prostatectomy to remove the prostate or radiation. So prostatectomy, for the most part, is done robot assisted these days. Some people still do it with sort of traditional keyhole surgery, laparoscopically or open. Previously, we used to do lymph node dissection, and it is still sometimes done, but most people have moved away from it because counterintuitively, removing the lymph nodes doesn't usually actually change the cancer outcome, and it adds to the risks and the side effects of the procedure. It's usually a 24-hour stay. You can see in the picture here where the prostate's removed, the bladder then has to be rejoined back up to the urethra. So during that time, while that joint is healing, you have a catheter in place draining the urine. So that's for about 5 to 14 days. The main risks related to the prostate surgery is the risks of urinary incontinence or leakage. Having said that, with the techniques of robotic prostatectomy, that's becoming a lesser and lesser issue, and people are recovering sooner. But sexual dysfunction or erectile dysfunction is definitely still an issue. The nerves that control the erections run around the outside of the prostate, and so they're at risk of damage during the surgery. And the extent to which we can save those nerves depends a lot upon the characteristics of the cancer for that individual person. For radiation therapy, this is high-powered X-ray beams that are directed at the prostate from outside the body. Generally, it's about a 4-week treatment. The dose and the frequency depends on the prescription by a radiation oncologist. The radiotherapy can affect the organs around the prostate, although their targeting is getting better and better. So there can be damage to either bladder or bowel, and so we sometimes help with the radiation side of things to put in what's called a spacer, so a hydrogel that goes between the prostate and the bowel to give it a buffer so that they're less likely to have side effects. Focal therapy is something that you may have heard of as well. It's something that has relatively early evidence. So we do recommend that it's only considered as part of a trial. So understandably, if we're only treating part of the prostate rather than the whole prostate, you're going to have fewer side effects. However, the problem is that prostate cancer is often multifocal. It may not just be in that area where the MRI identified the lesion. So you could have cancer growing outside of the area treated, or it's possible to have recurrence in the area that was treated, in which case you may end up needing radical treatment down the track anyhow. But it is a growing area of interest. We would, as I said, recommend it on a clinical trial. So metastatic disease, this is really where a lot of the research in prostate cancer is, and a lot of the growth in terms of treatment options. It's hard to do it justice. We've long known that prostate cancer is dependent upon testosterone, male hormones. And if we block testosterone with nowadays chemical castration, traditionally you would actually have an orchidectomy and remove the testes. But if we block testosterone using injections, then we can control the cancer. That used to be all we would use, but these days it's much more common to be multimodal. So we use traditional ADT, those injections, plus a novel anti-androgen, so an ARPI. These ARPIs are tablets, and there are more and more of them coming on the market. Usually ADT will be given in combination with an ARPI, or if there's a lot of cancer, then chemotherapy may still be used. But chemotherapy is not commonly used. We focus more on testosterone-related treatments. If there's only a couple of spots of cancer outside of the prostate, it may be that we don't need to treat the whole body. So you could just have targeted radiotherapy, and that's what we call stereotactic radiation. Or on the other end of the spectrum, if the hormone treatment is no longer working very well, some of those ARPIs can help, but also PARPI. It's ridiculous, the names that they're all coming up with. But anyway, olaparib, these PARP inhibitors are drugs that are only effective for people who have certain genetic mutations, such as the BRCA mutation. So that's where the genetic testing really comes into its fore. The other thing that we can use are radiopharmaceuticals. So basically systemic radiation that is attached to something that will bind to the cancer and just selectively treat the cancer. There's a lot in this space, and it's ever growing, and there are also many, many clinical trials. So we do have many options for metastatic disease treatment. The other thing I do want to comment on is the importance of exercise. So there's really good data that exercise in prostate cancer reduces the risk of recurrence. It improves your survival. both from the cancer point of view, but also, of course, understandably all cause. So it's going to affect, you know, your heart health and other things that you may run into problems with. So, winter of prostate cancer. From a take-home message point of view, PSA testing enables early detection of asymptomatic prostate cancer. MRI and PET, so imaging has totally changed the way we diagnose prostate cancer, and PET has also, I didn't get a chance to speak about it, but changed the way we follow up people with treated prostate cancer. So anyone who's had a prostatectomy, for example, we would recommend they have PSA monitoring for life, because even if the cancer comes back at a late stage, we can detect it really early and pinpoint it on a PET scan so that we can deal with it before it has a chance to really spread. Definitely want everyone to take home the message that not all prostate cancer is the same. There are a large number of men who at diagnosis will have low or favourable intermediate risk disease that we can monitor, and we need to tailor the treatment to the individual. And it's definitely an area where our treatment options are ever growing, as are the diagnostic tests. My recommendations for further information: the Prostate Cancer Foundation Australia is outstanding. They've got fantastic resources, and of course the Cancer Council. I've got on my website links to a variety of resources. I'm happy to take questions on prostate cancer. If there's an interest in a few brief comments on treatment of benign prostate issues as well, I'm happy to go in that direction, so I'll take your lead.
Right.
John, can I just interrupt a minute? Could we ask everyone who's logged in to mute themselves, please? Everyone, thanks.
Brian, I was quite enjoying that dog. Okay. Fairleigh, I think what we might do is take some questions, because I think audience always likes to ask questions.
Please.
And I might just quickly lead off. What you've outlined is a lot of changes. They're all small and they're all highly technical. But if we had to summarize it, you know, the simple question is, are we winning, and by how much have we improved our performance in dealing with this? How are the figures? If we take a 30-year or 50-year view, how much have we changed in terms of overall survival, etc.?
It's difficult in terms of the overall survival. We've only seen an incremental change, and that's because we are diagnosing, our patterns of diagnosis are different. But I'd say the two things that have changed the most is reducing over-treatment of low-risk disease. 10 years ago, or even less than that, if you had Gleason 6 disease, you would still have surgery to have your prostate removed, and that was probably over treatment for most people. So I think it's really important that we've changed that. And the other end of the spectrum is where we've seen change, and these ARPs, these novel anti-androgens, have really changed their treatment options for actually for anyone with metastatic disease. So they're the two things I think that have shifted the needle in terms of patient outcomes.
Right. The other question I have is the possible parallels with breast cancer. It's often said that there are 10 different types of breast cancer, or 15 different types of breast cancer. And some of those are quite specific as to where they're located. You know, I mean, Paget's is on the nipple, etc. You've got them where milk is produced, or you've got them in the ducts, etc. So when we go through this and the sites and locations affect survival rates and the rate of metastases, etc. So can we disentangle? One of your very early slides showed various categories where you'd taken the gland and you categorized it into different groups, A to D or F or whatever it was. Can we talk about that in the same way as we do with breast cancer, please?
It's generally less important to us than it would be in breast cancer. So anterior zone tumours potentially have a less aggressive, but when we're reporting a new diagnosis, we don't report the specific location because it doesn't really affect the overall survival generally. What we're mainly interested in is that Gleason score, and then if there are any specific pathological features. So most patients have acinar adenocarcinoma. So if we say prostate cancer, we just mean garden variety adenocarcinoma. There are some subtypes like small cell or which is neuroendocrine, or cribriform or ductal, which are subtypes that would confer an increased risk of a poor performer. But for the most part, the location itself is not that important.
Right. Okay. But I think if I can go back to my question on winning, what you're telling us is that unnecessary operations, radical treatment, have declined because we're now being more sensible and graduating and customizing what we're doing. I have a basic question though, a really simple question. What on earth is the prostate doing? What's its role?
Not a lot. So it produces some fluid that goes into the semen and helps liquefy the semen. So you're totally fine without the prostate. The issue, of course, is with surgery. We're disconnecting the ability for semen to come out. So for fertility purposes, obviously that's important for younger men. But from a functional perspective, you don't really need it. It's really just about that fluid.
Thank you. Brian, are you just about ready to pick up some of the questions? And if not, I will.
Yeah, that's fine. There's quite a few coming through, so perhaps we should handle them. I think we'll start off with one from Matt McNamara, who says, do we need to do both PSA and DRE for best prevention and diagnosis?
That's a very good question. So my practice would be and I think a lot of my colleagues would concur, if the PSA is clearly abnormal and pushes you into, on repeated testing, pushes you into the threshold for Medicare funded MRI, then I would just go straight to an MRI. So I would say, look, let's not put you through the examination. We'll do the MRI. That will give us more detail. If the MRI comes back as clear, but we're sort of in a bit of a grey zone as to do we need to investigate this further, then I would do an examination to say, is there a nodule or something that would push us over the line to say, yes, you need a biopsy. So I think there's definitely a role for the rectal examination. It doesn't have to be for everyone though. It's also being used less as we rely on MRI, but MRI is imperfect. As I said, only about 90% of cancers get detected.
I think most of us are familiar with the finger up the where. And there's a question here from Paul Lamont that does an enlarged prostate carry greater risk of getting prostate cancer?
No, funnily enough, it doesn't seem to. It doesn't. One of the tablets that people can be on for enlarged prostate would be Duodart or dutasteride, which shrinks the prostate. And initially there was a concern that there was an increased rate of higher risk cancers with that, but they think it was probably a needle in the haystack type phenomenon where you shrink the benign tissue and then you find the cancer. But so no, the larger prostates don't tend to have a higher rate of nasty cancer.
From Andrew Montford, and this is an issue of if you have cancer elsewhere, for instance, in the bladder, are you at a higher risk of getting prostate cancer?
Generally not, unless you happen to have one of those familial or genetic type syndromes. So you mentioned bladder cancer specifically. Bladder itself less so, but bladder is usually what we call urothelial cancer, so the lining of the urinary system. That can be a similar cancer that affects what we call the upper tract, so up in the lining of the kidney. And there is a syndrome called Lynch syndrome, which links bowel cancer and that upper tract cancer, which is like bladder cancer and prostate. So it's not, so there are some cancers that will be associated, but having one cancer per se won't necessarily increase your risk.
Okay, Michael Hall has made reference to recent research at Notre Dame showing LED-activated fluorescent dye being effective in selectively destroying some cancer cells. And he's asking, has this been looked at in reference to prostate cancer?
I don't know the specific study that you're talking about, but a fluorescent dye. Could I have a little more information about that?
Okay.
Michael,
Hello.
Yeah.
do you want
Hi.
to put your hand up?
Hi. Yes, it's a recent study of about 2 weeks ago.
Oh, right.
I think it was not in vitro rather than in humans, and it was small rice grain sized LEDs that were
right.
used to activate fluorescent dye that caused the energy levels of the cancer cells to which they were directed to be greatly increased, and it was an ACTH cycle interaction, and they basically exploded with more oxygen. So it was a way to selectively target cancer cells in areas that would not otherwise have been accessible by locating a very tiny LED light close to the cancer. So there's nothing on that that you know.
No, not that I'm aware of. I mean, the closest thing in human that's in practice rather than in research would be the lutetium, where, you know, we're injecting something that is going to attach selectively to the cancer cells and be able to treat that specifically. Because one of the challenges is, identifying all of those locations of cancer and with selective treatment.
Okay.
But no, there may well be work in a lab somewhere, because there are many, many, many labs around the world working on prostate cancer.
All right. Before I go, there was another question
course.
later on for me.
Wait on, Michael. We'll pick that up later, please.
Oh, dear.
Fairleigh, you made reference to fitness and exercise and whatever helping here. Robert Craig has asked, is there any evidence that cycling can actually increase the risk?
No. I did chat to a group of cyclists once, and one of the I guess conflicting information that you do get is, does cycling affect your PSA? And so there's no evidence that it changes your prostate cancer risk. People used to say, oh, you need to not cycle before you do your PSA, but they've done quite a few studies, and you really have to be talking about cycling like hundreds of kilometers before that pressure on your perineum is likely to make a big difference to that blood test. But no, cancer risk, there's not an issue. And I guess just to add to that comment about exercise, we see it as such an important part of treatment that certainly anyone who has any metastatic disease and who's getting systemic treatment, I would encourage my patients to see an exercise physiologist and get a dedicated exercise program, so something that's tailored. So it's not just about general movement, it's about getting something from someone who can really assess what your strengths and weaknesses are in order to help your better overall health.
Nigel Officer has asked, can you get a second opinion on biopsy pathology?
Yes, very much so. And we would do that routinely, actually. Not routinely, but if someone came to me for a second opinion about what to do with their cancer, the first thing I would do would be to get their case reviewed in our multidisciplinary team meeting, which involves a radiologist, a pathologist, and obviously the urologist and oncologist. The purpose of that is the initial slides will get reviewed to check if they agree with that initial diagnosis, because as you saw from that picture with the Gleason score, there are subtle differences in the cell, what the cells look like, and unfortunately not everyone is as experienced. We're already starting to see AI involved in studies in reading pathology, but at the moment it's definitely still human-based. And so myself and my colleagues are pretty particular with where we send our biopsies, because we trust the reports that we get. But yes, that was a very long answer to say 100% we would get a second opinion if there's ever any doubt.
Now, on that issue of the competence of some of the specialists here, you did make a comment about the MRI being done by specifically a specialist who is familiar with oncology and
Prostate,
a
yeah.
radiologist. Does this mean that if any of us are up for that, that we should seek your opinion or other specialist opinion as to where we should get MRIs done?
Definitely. So in order to get Medicare funding for your MRI, the MRI has to be ordered by a specialist, so an oncologist or a urologist. If your GP orders the MRI, you don't get the Medicare rebate. So it's a few $100s that you save. But more importantly, if you're having a specialist order it, they're more likely to be able to guide you somewhere where you can get a good scan. So, for example, I spoke to the business development manager at a place I routinely order scans, and I said, I know you've got MRI scanners at other locations, but I only send my patients to these couple of suburbs. Can I send them to the MRI scanner there? And they said, no, even though we've got the scanner, we don't have a dedicated MRI prostate specialist, and we're not willing to do the scan unless we know we can report it well, which I think is the right way to go about it. But unfortunately, some places are just keen to make a buck and not so interested in keeping the quality good.
Now, Dick Davies has asked, are the GPs on top of all this latest research, and are they capable of giving us the right information about what we should do?
Oh, look, I think I take my hat off to the GPs. I think they have a very tough job. I think that there's a lot of contention around prostate cancer, and I'm not surprised they can get confused with it all. I know that the information from the states about stopping PSA testing 10 years or so ago percolated through to the GPs locally, and so there are a lot of GPs who do recommend against PSA testing. I think there are a lot of GPs who are very well informed. So at the end of the day, PSA testing should be an informed decision and a discussion you have with your doctor. So I would say most of them are able to have that discussion. And if you feel you've got more questions answered, then a urologist's always happy to see you, even just for an initial assessment and a discussion, even if there's not an abnormal PSA necessarily.
Now we've got a further question about enlargement. Paul Hoff has said benign prostate enlargement can nettles, i.e. the stinging kind, reduce size and symptoms, e.g. frequent night urination, etc.
There's not a great deal of evidence in terms of complementary therapies for benign prostate enlargement. Probably the best evidence would be for lycopenes in tomatoes, watermelon to perhaps reduce the PSA, maybe help symptoms, but nothing conclusive. So specifically with nettles, I couldn't say, but there's nothing that we would can strongly advocate for patients.
Right.
Now, you did.
Can I come in there?
Sorry, John.
That's taken us onto the benign part. Do you, Brian, if you got any, do you want to go your next question and then?
No, well, I was going to suggest that maybe we should, because I think there is some interest in.
Yeah. So I think we can move to your benigns.
Okay,
Yeah.
great. Let me just.
That's what I was
share
trying to do.
that.
Yeah.
Okay, that's back on. So, again, just a very brief summary, but we've known about benign prostate enlargement for hundreds of years. There are a few different things that happen with the prostate when it gets bigger and the reasons why it causes symptoms. So there's the static obstruction, so the simple enlargement of tissue causing a blockage from the outlet, and that responds to drugs like Duodart, which has a couple of things in it, but dutasteride, finasteride. They act on a subpart of the testosterone pathway, and they act to shrink the prostate tissue. Because it's acting to shrink the tissue, it's not going to work overnight. It does take 6 to 12 months to have its full effect. And you can imagine, because it's on the testosterone pathway, there is the potential for some sexual side effects related to that blockage of the partial blockage of that pathway. The other thing that happens as you get older is you get increased smooth muscle tone in the urethra, in the prostatic urethra, the water pipe. And that's where we use an alpha blocker. So medications such as tamsulosin, silodosin, or Flomaxtra, you might have heard of, that just relaxes the muscles on the inside of the water pipe. So that's probably the least invasive thing we can do for people, is use that kind of medication. The risk with that, particularly as people get older, is that there can be a small crossover into the blood vessels, such that if you have relaxation of your blood vessels, you can have a slightly lower blood pressure. So if people get dizzy, then we say, stop that. Most people are absolutely fine on it, but that's something we are slightly cautious with. If your bladder has been working against a blockage for a long time, you can get secondary changes to the bladder muscle. Initially, that's urgency and frequency, and we can give you medications to help settle those symptoms. Initially, the bladder compensates okay, but in time it can decompensate. So the bladder just gives up and says, I've been working too hard for too long, and the bladder muscle just can't help to squeeze that urine out. And unfortunately, the bladder muscle is an involuntary muscle. It's not like going to the gym and doing your bicep curls. You can't just build that strength back up again. So that is something we need to think about when someone comes in with urinary symptoms. Is it related to the blockage, or is it related to the bladder muscle? In terms of surgery, I knew this wasn't the focus, so I've just got a whole lot of pictures, but the most traditional surgical treatment would be a TURP, so transurethral resection of the prostate. That's pictured up in the right top corner there, under general or spinal anaesthetic, camera in through the urethra, and we're shaving away chips of prostatic tissue from that central part of the prostate until you've got a better channel to pee through. You have a catheter in, it's a 1 or 2 night stay in hospital, and that's really been our gold standard for decades. If your prostate's very large, and everyone's definition changes, but probably over about 150 or 200 cc, people used to do what's called a simple prostatectomy. So that's not removing the entire prostate, but this sort of picture second from the right on the bottom, where the person's finger is down in the prostate. Basically, you're just shelling out the central part and leaving, if you will, the orange rind on the outside. And that can be done either open or robotically. More recently, people have moved to using laser technology. And so the HOLEP is the holmium laser enucleation of the prostate. Basically, what that tries to do is use laser to replicate that open technique of shelling out the central tissue and leaving the rind. And it's a lot more minimally invasive. You have a catheter in overnight, and you don't have any size limitation. So that in theory can be done on very, very large prostates that previously would have required open surgery. Green light laser is another different kind of laser, which doesn't actually remove tissue, it vaporizes it. So you don't get any tissue to send off to the lab. But when we're doing these procedures, for the most part, we're doing it because we don't think there's cancer. So you're not as fussed about getting tissue to send away. The next group of treatments is what has been grouped as MIST, so minimally invasive treatment. These do get a lot of airtime in the press. So resume water vapor therapy is the picture on the top right. In some places they do that under local anaesthetic. Mostly in Australia, we do a lot of our procedures under general. It's a very quick procedure. It involves injecting steam into the prostate in a way that you then, the steam basically burns and kills the prostate tissue. But like those tablets, it takes time for things to shrink. So really, it takes weeks, if not months, to see the full effect. And just like if you get a burn on the skin, there's an initial swelling and pain related to that. So you do have to keep a catheter often for about a week before that comes out, just to deal with that local irritation initially. The next thing is Urolift. which is on the bottom left, the yellow picture. That's again put in with a camera, so a cystoscope, but it's these little implants that have got, that are designed basically to compress the tissue. So you're not removing any tissue, you're just compressing it so that you have a channel with which the urine can flow. In the middle picture, you've got an illustration regarding prostatic artery embolization. So this is a procedure done by the radiologists where they go in via the groin and actually block off the blood supply to the prostate, which also acts to shrink that. So similarly, that doesn't happen straight away, but over time you do get some shrinkage, and that's mostly reserved in Australia for people who are not fit for any of the other procedures. But now that we've got things like Urolift or Resume, these are pretty minimally invasive, so we do have quite a few options for people. Unfortunately, urethral stents have not been super successful. And foreign bodies in the urinary system tend to encrust, they grow stones. So stents are sometimes a short-term solution for someone who's really got an incredibly short life expectancy and who perhaps doesn't tolerate having a catheter in the bladder. But it's not our mainstay of treatment. But I know a lot of people often ask me because, you know, there are cardiac stents, why aren't there urethral stents? So it's an area where a lot of people continue to do research because it makes sense that it would work. But it's not, for the most part, it's not part of our mainstay of treatment. So that's kind of the shopping list of the treatment options.
Okay. Can I come back to a question which Raven Crawley asked, and I think you've partly answered it, which is obesity, diabetes, alcohol are usually cited as risk factors for many cancers. But you've told us that the environmental side and the correlations with other cancers aren't high. So does it matter? So does obesity or diabetes?
No, yeah, obesity does make a difference. Yeah.
Right. Okay. Right.
John, can we pick up another question? We'll give Michael Hall another go.
No, he's left the stage, I think.
Well, we'll still have his question. Prostate size can be increased by growth in cell numbers and cell size growth. And how does the PSA density measure interact with these differences? And I wonder, Fairleigh, you did talk about density and size. Perhaps you could sort of clarify that issue for us in terms of whether it is just stopping us pee a bit more or whether it's cancer or whatever.
Yeah, look, I don't know that anyone has compared the PSA specifically to the cell number or cell size of the prostate. Density is really just a measurement of the volume of the prostate. We do sort of loosely interchange grams and mils, so it's just an estimation of volume. The density is just a crude measurement for the size, I guess correlation with the size of the prostate. As a general cutoff, anything a density of under 0.1, we're very comfortable that we're incredibly unlikely to be missing any lesion on the MRI. A density of 0.2 or more, there is a significant chance that there's a cancer that the MRI hasn't detected. 0.1 to 0.2 is the grey zone. Some people say 0.15 is the cutoff of normal, but they're the kind of things that go through my mind. If I see someone with a normal MRI, I'm thinking about those numbers. If their PSA density is close to 0.1, I'm more happy to sit tight. As it gets closer to 0.2, I'd be suggesting that we think about a biopsy to make sure we're not missing something.
And we've got a question here. What are the full recovery rates post-surgery for incontinence and also erectile dysfunction?
So incontinence, as a rough rule, I'd say 90% of men are continent at 12 months, and it'd be less than 3% who have a degree of incontinence that they would need to consider surgery for that. But there are quite a few factors that go into continence. So obesity definitely does play a part. Someone's general fitness and health. Doing pelvic floor exercises is really important. So I would get anyone who's having surgery to see a physio for education beforehand. And I know some people say, oh, I know how to do those exercises, but actually they see you with an ultrasound and get you to activate those muscles. So you can see those muscles move on the ultrasound and know you're activating the right thing. So physio makes a big difference. If you've had previous other procedures on the prostate, so if you've had a TURP or if you've had radiotherapy, so let's say we're doing salvage surgery, if you're having surgery after radiation, then the incontinence rate would go up. Erections, it depends a lot on your age, on your pre-existing erectile function. So if the erections are poor to start with, then the chance of them getting worse is significant. Even if you've got decent erectile function beforehand, I would say probably a 50% chance of erectile recovery, and most people need tablets for that. So it's easier to go into it thinking we've got options to treat the erections, but I'm not going to assume they're going to come back. The primary focus really has to be, if you're going down the path of treatment, that we're trying to get rid of the cancer as our primary objective, and obviously maintain highest quality of life as possible. If tablets like Viagra don't work, then we also use like vacuum erection devices or injections. Injections do work for most men. Or if none of these things work, then some people do go on to have a penile prosthesis, but that would be the minority of men who do go on to have that kind of surgery.
Okay, well, Fairleigh, look, thank you very much for all this, John. I think given the time, I'll pass it back to you now.
Right. I might do the same, but I think Fairleigh, you've given us a very rapid run through. When I saw the number of slides, I went, oh, we're going to go over time, but in fact we didn't. You could go over time because you were so fast through them. But I would predict that our digital archive, which houses all our presentations, this particular presentation, I'm sure people will be going back to it to say, this could fit me or one of my best friends, or I just want to know about X and Y, because you've been very precise and very detailed. And I know this is a presentation which is going to bear greater scrutiny after the event, just as much as it's borne a lot of scrutiny during the event. I think the fact that we had 115 registrations, we actually had more than, I think we actually had 72 people online. That is one of our best presentation performances in terms of attracting an audience, and we want to thank you very much for being so clear, so detailed, but also giving us the overview. So Fairleigh, thank you very much indeed.
Thank you very much. Thank you,
Thank you for the
Fairleigh.
invitation.
Right. May I take your time, Fairleigh, just to quickly sketch that next month we have Professor Ian Barr from the World Health Influenza Reference Centre speaking on avian flu and all the other soup of lurgies known as respiratory viruses. The following month we have Len Harrison from the Walter and Eliza speaking on the microbiome and its widespread effects for health, whether it's the gut or the mouth or any other part of the body. The biome is critical and one of the frontiers for health at the current time. And then almost as an experiment, we're going to hear Warwick McKibben, who's an international economist based at ANU and working in Washington, DC, on the macroeconomic impacts of a second Trump presidency. It seems even more relevant after the weekend's events. Thank you very much, Fairleigh. Thank you very much to our audience. We'll leave the line open for a few minutes. Fairleigh, thank you very much indeed.
You're very welcome. I should have said, if anyone has any questions, you feel free. There is a spot where you can send a message through on my website. So more than happy to be contacted there.
Well, that's in keeping with your generosity generally. Thank you.
No problems.
Thanks
Thank you
very
very
much.
much.
Thanks very much.
Well, hello, gentlemen. You're all there. Any comments on and what you didn't ask? Alistair
Right,
Fisher.
should I leave you to it?
Yeah, thank you, Fairleigh.
Thank
That's
you,
terrific.
Fairleigh.
We loved it. Thank you.
It was
Alright.
brilliant, absolutely brilliant.
Terrific. Right. Okay.
John, can you hear me, John?
Yes, Nigel. Yes.
Where will the record, when and where, from where would the recording be available? And copies of the slides, is that just done through the club or?
I actually do have copies of her slides, and we don't usually put them up with it, but I'll check with, there's undoubtedly a little bit of IP in there. I'll check with Fairleigh about whether we can put the slides up. I think she'll say yes, and we'll put them up jointly with the recording. The recording is available to club members, deeply buried in the website. I even had a ex-club president last month ask me where do we find them, and I thought he should have known, but I was delighted to have his question. So we will have those available. And just for the record, and something I didn't bother Fairleigh with, but I don't know if you recall one of our those of you who've been watching these since 2020, we actually had Professor Vanessa Hayes from the Garvan Institute talk to us on evidence of ancient man around the Botswana lakes. Why? But how does she justify doing all this side research, which is very interesting, and be employed by the Garvan? And the answer is she is a specialist in the genetics of prostate cancer, and the rate of prostate cancer amongst the Click people, who are very important in the lineage of modern humans. They have a phenomenal rate of prostate cancer. It is so it was mentioned that it's higher for Africans. It's exceptionally high for the Click people of Botswana, around the Botswana lakes, and that's also still available on our website.
Thanks, John.
Okay, so look forward to seeing you all next month. And I just want to issue another invitation, and that is, we've had suggestions. This is not the first. This one was suggested by one of our members who's still present. Looking at him now.
Still there. Good on you, Dick. Well done.
I wasn't going to name him. I was respecting him, but
He doesn't get credit for too many things, so we'll give it for
yeah, okay, well done, Dick. But we also had a terrific presentation from Miles Prince that some of you may recall on the recent advances in leukemias, blood cancers, and the importance of that. And that was introduced to us by one of our club members who basically got in touch with me and said, you must have him, and I agree. We had him, and he was just absolutely terrific. The advances that are going on in the cancers are really quite exciting and very encouraging. Right.
Righto, guys, I've got to go.
Yeah, I think we might all
Good to see you all
go.
again, and we'll see you next month. Cheers.
Yep. Be online. Look forward to seeing you all. Take care. Right. So we've still got Alistair there, and we've still got Mike Porter. G'day, Mike Porter. Right. So how did your particular National Health Party go with National Health System focus go in the election? Get any candidates up?
Oh, we only finished with one candidate, and the difficulty was that there were just so many candidates, and if you've got so many candidates, then you finish up that they all spoil each other's votes, and so it means that the big parties will get in as usual. And but if it's on a one-to-one basis, then we would have done quite well. But as it was, the person that we had standing was changed electorate very in Liverpool very late, and in doing so, it meant that his vote was much lower than he would have liked. It was only about 1%. But he would have, if he'd have gone in his own electorate, it would have probably been about 5%, and he would have got his money back. But that's really what's happened. That everything is completely fragmented in the United Kingdom at the moment, and it's not at all clear just whether whether Starmer's group is going to maintain the ascendancy. He's doing very well at the moment by the way that he's been acting, but I'm not sure that it's going to last for 5 years because of the difficulties that we have in the British economy.
Yeah.
John,
Yes,
I just want
yes,
to say hi to my roommate from the ship, the Orchidees. Is that Alistair Fisher there?
that is Alistair.
Yes.
I haven't seen you for 40 years, I don't think.
Oh, that's a minimum. It could be. It could be
We're on the boat
59.
together in 1962.
November the 28th.
Oh, Jesus. What did I do on that day? Sue and I have had dinner with Meg Grosvenor recently, and some other friends, Roy Masters. You remember Meg very well, I'm sure.
Well, I do, because she was a teacher at Darramarlin in Canberra, and that was while I was in Canberra, and I used to take her to school every day because she lived on one side of Canberra and not very far from me.
And she was a casual friend of Roy Masters. And our wives, we had a dinner together just to show it was a genuinely platonic relationship. The Masters and the Porters. There wasn't Masters and Johnson, it was Masters and Meg.
I have a nice photograph of Meg Grosvenor and Jill Marsden at the opening of the Peacock in Manuka, when we opened the shop for Asian handcrafts for money for Community Aid Abroad.
You heard about the time I met Meg. I was with Max Gordon, and we showed up the day that Lee Bum-Suk was made Deputy Prime Minister and President Chun inaugurated, and Meg's husband, Ted Pocock, was the ambassador to Korea. Anyway, Meg and I had this, Gordon and I had this amazing meeting with about the closing off of one of the car industry companies. And Meg threw a dinner. Ted Pocock threw a dinner, I guess, at their house. And I walked in the door with Max, and there was Meg. And we both blushed, and I hitchhiked to Kathmandu with her. And Ted Pocock said to me, Michael, why are you blushing? I said, well, I got a box full of photos of your wife, Ambassador. One of them, she's throwing cow dung against the wall. Anyway, that was a funny way to meet Meg. I had no idea she was the ambassador's wife. Anyway.
We actually, Jill and I went to their wedding. So,
Jesus, what a world. Okay, well, nice to see. How are you, Alistair?
I'm moderate, right. I'm pretty much okay, apart from the big prostrate. That's all.
Right. So when are you visiting Australia next, Alistair?
Oh, you're in England?
Well, the family were all, most of the families back migrated, and so they all want me in Australia.
Yeah, well, we all do. We understand that. That's why I'm asking.
Pardon?
That's why I'm asking you. We all want.
I didn't know you'd left. I'm sorry.
Well, I don't know what the answer is to that one, because I've been embedded in British society now for 30 years, or almost 30 years.
Is that right?
And I'm still doing quite a lot of work in terms of I mark papers for London School of Hygiene and Tropical Medicine. That's remotely, but I also do some other work, which is I do quite a lot of reviewing for some of the medical journals. So these things keep me more or less where I am for the moment. I'm not sure how long it's going to be before I'm going to tear myself away.
Well, we'll have to entice you out just for a visit.
Yes.
That's-
Well, that's quite possible, but I'm basically a hermit these days. So.
Well, we know that. That hasn't changed, but why don't you just come out and visit?
Well, as I recall, last time we met, you dressed up as an economic statistician. That's not what I remember you as.
Oh, well, actually, the last time we met, I was just an ordinary statistician, not an economic one.
Oh, you're in the economics department, though.
Well, did I meet you when I was in the economics department?
Yeah, I gave a seminar over there, and you had the misfortune to participate either in coffee, the staff club, or maybe the seminar. I don't know.
Oh, well, no, I got a job. You see, I did an economics degree at the ANU after I went to Canberra, and so I got into microeconomics like it was a complete change for me, and I really did extraordinarily well in certain bits of in certain bits, because I wrote a paper while I was in second year as an undergraduate there, which, if I'd have realised what I do now, I would have been able to publish that. Would have been quite an interesting publication back 50 years ago. Now I'm not sure, but what it certainly was. I don't think it would have changed very much, but it did make quite a bit of difference. It won the essay prize that year.
Well, I reckon that trip to India completely transformed me. My motivation and focus and work effort really changed. I mean, that was an amazing, powerful trip experience.
Well, I think that trips to the third world when you're under the age of 21 make an enormous difference to people,
Yeah.
and it's been the one thing that's changed my life more than anything else. And I do know other people who are in the same sort of situation. You've probably heard of Jeremy Corbyn. He spent a year in Jamaica as a teacher at Jamaica Boys High, and I'm sure that made a huge difference to him in the way that
I like to think these differences are positive.
Yeah, well, I have a woman yelled out yes from the kitchen there, over there. Hello.
Hi, Sue.
That's my dear. She went to India 2 years after me, and I think a lot of people were profoundly affected, and she too. We actually got married not long after she came back. Anyway.
Yes, well, it's the sort of thing that I think should be encouraged in a sense, but I think it depends on how you do it as well. And we were very lucky to have a group that managed to send everybody off into not only homestays but also going around by yourself in India. Which was,
Samuel, he got arrested because he went to the Chinese embassy in Calcutta, and he was then followed by security. It was quite fun.
Yeah.
Ended up with Rupert Murdoch, of course.
Yeah. By the way, I saw Nick Bryant, John.
Yes.
I think your latest, the previous guest, and he was on BBC last night saying that he thinks that America has now polarized, and he can't see that the polarization between the Democrats and the Republicans can be changed, and that that's not going to be easy to. It'll always be like that for the next, for the foreseeable future.
Well, I found his whole presentation absolutely convincing. I mean, you could nibble around the edges, but the idea that revolution, that rebellion, we're rebels. This is part of their ethic, which goes right back to the fact that they still think about overthrowing the British, and this is the central value, and it fits in with the 3%ers and the frontiersmen and and the boys and etc. It is just quite frightening the way he sketched that out, and the book is a terrific book to read, but it doesn't leave you very optimistic.
I must admit, I missed that. Yeah. Pity.
You heard it, right? You heard it. You did.
Michael or Sue, I'll lend you the book.
Okay.
I think I've
Anyway.
read enough about America, John. Thanks.
So
I've
whereabouts are
read
you living,
so
Alistair?
much about Trump and Biden and the division. I don't think I can take any more. Thanks.
Where are you living, Alistair?
Sorry?
Whereabouts are you living?
I'm not very far from Heathrow.
Oh,
I'm writing about Heathrow at the moment as well.
that'd be good. Is that an
Well,
accident?
you see, what happened was that they've got they proposed to have a third runway or fourth runway, and the question was, should you have a fourth runway in at an airport which is in the middle of a city? And the answer, I think, is probably no. So,
Yeah, one of my roommates from America, Stanford, Stephen Littlechild, he did a project with some very big names about the fight in the 1960s about another Stephen Littlechild. Yeah. Anyway,
Now, gentlemen, I'm going to have to go because I've got a wife I have to go and look
Good.
after.
I'm about to eat a very good meal.
All right. So, good night, Sue. Good night, Michael. Good
Nice
night,
to see
Alistair.
you.
good night, everybody.
And we will leave. Okay. Take care.